Today's my talk is about tips for writing case reports of MEG, which is based on my experience. Skill of writing or presenting case report is mandatory as a physician or medical scientist. Getting the skill is not straightforward or complex. In addition, no official curriculum exists. In this presentation, I will talk about a tip to find the topic of case report first. After that, I show you practical points for writing case reports by showing my past papers as example. To find the topic of case report, I recommend making a table to compare your case and past cases to seek the new point of your case. In the left column, any type of clinical or laboratory information such as clinical cause, seizure semiology, imagings can be included. And fill the table with the fact of your case and past cases. After that, mark equal when findings of your case are already reported. Mark not equal when your finding is new or not reported. Not equal points are candidates for the topic of your case. I present an example how to use this table. In the past, I successfully recorded ictal MEG of spasms. Searching PubMed clarifies that no paper discussed the ictal MEG of spasms at that point. These clinical experiences were finally published. Now, move to practical points for writing. Case report consists of introduction, case presentation, and discussion. In the introduction part, we need to be mindful of the fact that can even novice readers understand our paper? In other words, attempting to release audiences from knowledge gap is very important. You need to explain words shown in the title, because readers of your paper are not always professional with a theme. As an example, I present the title page of my case report I published in the past. This is a paper evaluating a mechanism of spasms with MEG. From the title, you can see the topic factors of this paper are spasms, underlined with red solid line, and MEG, underlined with red broken line. Considering that readers may not know about spasms and MEG very well, I start with an explanation about spasms, which is followed by that of MEG. After providing basic knowledge about this paper, finally, I can introduce the significance of the study. By having these steps, readers may enter the world of your paper without knowledge gap. In the case presentation part, select information crucial to understand the story. In this case, I recommend you to include pertinent not only positive findings, but also negative ones. I present an example, history of February seizures in mesial temporal lobe epilepsy. This is especially important in case of considering anterior temporal lobectomy. I mean, presence or absence of a February seizure is associated with the presence or absence of hippocampal atrophy. This difference brings different prognosis of anterior temporal lobectomy. In the discussion part, to clarify not equal or new points clinical significance, it will be important to construct convincing explanation about the phenomenon we face, or unitary hypothesis. In unitary hypothesis, the key is finding one cause which can explain all phenomena of your case. There are several approaches to create unitary hypothesis. First, create a hypothesis with your MEG result only. Second, create UH with your MEG result and the result of other modalities. Finally, create UH with your MEG result and knowledge from past published papers. Start with first strategy, creating UH from your MEG result. A 2-year-old boy who was diagnosed with West syndrome, who was treated with ACTH. Seizure was controlled transiently, but relapsed soon with two types of seizures. One was leg spasms, the other was generalized spasms. He was referred to MEG lab to receive simultaneous EEG-MEG recording, which captured the two types of seizures. From the left, EEG-MEG of interictal spike, leg spasm, and typical spasm are shown. EEG are shown with longitudinal bipolar montages, blue for left and red for right. Waveform, contour map, and the spike source of interictal, leg spasms, and typical spasms are shown. Source of interictal spikes, leg spasms are evaluated with equivalent current dipole model. Source of typical spasm are evaluated with DSPM. Source of interictal spike and leg spasms were estimated at right parietal lobe. Typical spasm shows early activation of right parietal. After that, activation involves whole brain. To identify not equal point, I made a table. This case was unique, as two types of spasm existed, although no paper discussed the ictal image of spasm at this point. At the unitary hypothesis, I hypothesized that right parietal area was primary source. Different seizure types could be explained with the presence or absence of propagation. In this case, unitary hypothesis is two types of seizures may originate from right parietal, appear with different cortical involvement pattern. Clinical significance of this study is MEG may be helpful to evaluate mechanisms of spasms due to its non-invasiveness and good spatial coverage. Move to second strategy, creating UH from your MEG result and the result of other modalities, here with ictal spect. 23-year-old female patient had infarction in right frontal lobe in neonatal period. From age of 7, she started having a seizure. Initial seizure semiology consists of bilateral asymmetric tonic seizure. She received dissective surgery of right frontal lobe at the age of 13 because of intractable seizures. However, her seizures were not controlled. Of note, after surgery, seizure semiology changed. Cephalic aura appeared, which was followed by bilateral asymmetric tonic seizure. Left two columns shows interectal and ictal aura. EEG are shown with longitudinal bipolar montages. Of note, only MEG captures interectal spikes and ictal fast activities. Spike source of interectal and ictal activities were estimated on the edge of resected right frontal lobe. The patient received ictal SPECT, which showed hyperperfusion in the right lateral to medial frontal lobe. Right lateral frontal is the area of interectal spike source and ictal onset. Right medial frontal is the symptomatogenic zone of bilateral asymmetric tonic seizures. Based on the results, I hypothesized that seizure came from the right lateral frontal and propagated to medial frontal. To identify not equal point, I made a table. This case was unique, as MEG captured ictal fast activity during epileptic aura, which has never been reported. From the result of MEG and ictal SPECT, I made unitary hypothesis that seizure came from right lateral frontal, which propagated to medial frontal. Clinical significance of this study is MEG may be helpful to evaluate brain activity during epileptic aura. Move to third strategy, raise creating UH from your MEG result and knowledge of published papers. 8-year-old female patient diagnosed with Aicardi syndrome, where spasm as a symptom. Because of seizure intractableness, she received EEG-MEG evaluation, which recorded spikes and spasms. Left two columns shows interectal and ictal recording. EEG are shown with longitudinal bipolar montage. Interectal MEG shows clear, sharp wave, although EEG shows only slowing. We call it MEG unique spike. Curiously, ictal MEG shows different spike amplitude even in single series of spasms. In the process of searching related papers, I found a study which evaluated spasms with intracranial recording. It clarified variable cortical involvement pattern even in a single series of spasms. To identify not equal point, I made a table. This was unique, as different spike amplitude in a single series of spasms, although no paper discussed the ictal MEG of spasms. From MEG result and the past published paper, I made unitary hypothesis that MEG spike amplitude differences may reflect variable cortical involvement of spasms. Clinical significance of this study is MEG may be helpful to evaluate spasms mechanisms due to its non-invasiveness and good spatial coverage. This is the final slide. I introduced an approach for writing case report in MEG. I recommend you to find 3 points: not equal point, unitary hypothesis, and clinical significance. Of them, it will be the key to create UH. You may create UH with your MEG results only, or your MEG result and the result of other modalities, and your MEG result and knowledge from past published papers. Thank you for your attention.